Hello and good evening, everyone. Welcome to our 53rd Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Ino Tadela, a general physician and first aid trainer from Blue Health Ethiopia. It's a pleasure to have Dr. Abnet Ayalew back again with us to give a session on the topic medical certification of cause of death. You might remember Dr. Abnet from her previous sessions on medical error and negligence, and also the death process and confirmation of death. You can find her previous lectures on our YouTube channel. Dr. Abnet Ayalew is an assistant professor of forensic medicine and toxicology at St. Paul Hospital.
So thank you. Good evening, everybody. We have taken a few minutes as we've been preparing. So I'll just go directly to the presentation. I hope we've met with some of you in the previous sessions regarding forensic topics, similar forensic topics, and today would be the medical certification of cause of death. I'm bringing this topic as it's not particularly specific to forensic medicine discipline, but however, as a discipline that majorly deals with legal conditions concerning the medical field, forensic medicine is where you get the better perspective regarding the cause of death and its process of medical certification. So my goal in the future and my recommendation is so that this particular topic be given in a form of a training, in personal training, and this also be included in undergrad medical field studies. Also with forensic medicine, at least the introduction part to be included in the undergrad curriculum so that we could be familiar and we could speak the same language regarding this concerns. So I would go to the presentation. What does it mean when we say we have the death certificate, death notification form, and medical certificate of cause of death, abbreviated as MCCOD? Death certificate is the legal document which you have as birth certificates, marriage certificates, and all. That's what death certificate means. So it's a legal document and vital record issued and signed by registrar of death. It contains cause of death and is demographic information. So it's like the other certificates. It's issued by the registrar of death or registrar of vital events in depending on the state. So death notification is what health professionals use. It just means the capture of information of death that the person who has been in the community or in the hospital has been found dead, or as he has been under the care of the hospital, that the date has been recorded. A health worker captures the information and transmits the information to civil registration in order to support the record of vital events, and it occurs via death notification form. The major concern for us as medical people is the medical certificate of cause of death, MCCOD. So it's the assignment of cause of death. This is what makes it different. The cause of death, the manner, and the other aspects are done in detail, and it's used beyond legal documents. It's used for different authorities regarding the health of the nation and the state. So medical certification of cause of death means assignment of cause of death by an authorized medically trained clinician who fully understands the clinical sequelae of disease or injury that led to death. So here for the general consensus, it's given as authorized medically trained clinician. However, there are states where coroners and other legal authorities also certify the death, but it should always be noticed or remembered that these authorities, even though they are not medical people, they should ask for the opinions and help from the medically certified clinician. So how is the global consensus? What's the agreement regarding the medical certification of cause of death? International medical certificate of cause of death is provided by ICD via the WHO. So it should be the other way, by WHO via ICD. ICD is actually ICCD. It should be ICCD. Currently, it's on its 11th edition. It's a form that gets revised about 5 to 10 years interval, or 5 to 7 years interval. It's done by the WHO, and ICD or ICCD means International Classification and Coding of Disease. So the main point is, after certifying the date, it should also be coded. The cause of death, the disease, or the injury that led the individual to death should be coded. It's not only just certification of death, but it's also coding. The entity, the cause of death, should be coded. So why do we need a standard certificate for the cause of death? It's to provide standard format where demographic and medical data are entered about the death and the deceased. So where we're still worried about the medical data and demography concerning the death be registered, we'll see the purpose of the MCCOD in the next slides. So MCCOD is designed to help the certifier to provide clear consequence of events leading to death in ascending order. We'll see that in detail. Certifier of death. The certifier of death is the physician, the medical examiner or coroner who completes the cause of death section. This is the major duty of the certifier of death. Why does it say the cause of death section? Because different nations adopt the standard medical certificate to their own accord, and some nations add sections where it is filled by other authorities and servers, like funeral home servers and registration and recording authorities, and also the certifier of death is mainly the one that fills the cause of death section and of the certificate that also includes details about the circumstances surrounding death. Also, the certifier of death, even though different authorities participate in the filling of the certifier of death, depending on the adoption of the nation of the standard certificate, the certifier is the one who signs the medical certificate of cause of death. So who should do the medical certificate of cause of death? Regardless of requirements of the law of the country, whether it's done as the law or not, it's the professional responsibility of the attending doctor to complete the medical certificate of death. So that the recommendation is that we adopt filling the medical certificate in a correct way and attaching the record in an appropriate way as the end of life care for the patient, like we do for while the patient is alive, like we document whatever treatments we're giving or whatever plans we have in the future for the patient. When the moment comes and unfortunately the patient dies off, we should extend the care as the end of life, as if the patient is alive and it's part of the care. So medical certificate of cause of death should be part of end of life care. That's the recommendation. A team of caring physicians should discuss on the sequence of events leading to death. It's not always very easy and straightforward to determine what caused the death, and cause of death and the rest of the components are mainly opinions by the certifier of death. So It depends on the information you have, on the perspective you have. So the more team and the more information you have about the patient and the circumstance of death, the more likely you're going to make an accurate decision regarding the cause of death and the manner and the likes. So it's advised. Also, it's not easy to always determine. It's not always straightforward. What was the underlying, what happened in between, and what happened immediately to cause the death. So it's advised that the team of caring physicians discuss on the sequence of events leading to death. If no doctor was available when the death occurred, verbal autopsy is recommended to gather as much information regarding the death, and the MCCOD can be completed based upon. So if you don't know, if you were not around when the death occurred, and let's say the dead body was brought to you at the emergency unit while you're working there, you should ask people about the circumstances of death, where they found him, the condition, whether he was bleeding, if he was vomiting, if there was a different smell, or whatever, if he had habits, if he was known to the community, or if he is a stranger and all, so that you can identify the cause of death and the other conditions more accurately. So even though you're attending a death of a person whom you have no idea about its existence before or his existence before, you're still expected to fill the death certificate regardless. It's still your duty. If you have been called to the death scene, or if the dead body was brought to you, it's still your duty to fulfill the medical certificate of death. In case of accident or violent deaths, traffic police people or such authorities could provide further information. So don't disregard these people, don't disregard any information, especially in cases where you have not attended the patient prior to the death. Forensic pathologist could fill the medical certificate of cause of death for cases for whom autopsy or postmortem examination is performed. However, it's still the responsibility of the death certifier, except in few cases. There are few cases where the clinician at the emergency unit is not recommended to fulfill the medical certificate of death. But still, it's not the sole responsibility of the forensic pathologist. It's still the responsibility of the death certifier. Whoever confirmed the death, whoever was taking care of the patient priorly, should fill the medical certificate of death. So what you could do rather is gather information from the postmortem examination and complete the medical certificate of cause of death, including the information from the forensic examination. So this is the summary of key steps in filling the medical certificate of cause of death, or medically certifying the cause of death. As you get the dead body, examine, collect as much information as you could get, and then formulate sequence of events. This is the recommended steps. After you've done the examination, the history, the circumstances, and everything else, and the investigations, if you could do that, the recommended step is to formulate sequence of events leading to death before you jump to filling the medical certificate of cause of death. And then you fill, and then coding should not be omitted from the step. After you code it is where you can be called as you have completed the medical certificate of cause of death. So how to code and details of everything when it's death from injuries, when it's death from maternal conditions, fetal death, or from other diseases, from poisoning and all, you can find it in the ICD-11 format. It's a lot of details and it has its own code. So for each cause of death, you need to give a code, and generally that's the code for the whole certificate. That's what it means. The other is time interval to complete the med. We'll see the certificate in the slides in the near future. State specify time interval after death to completion of medical certificate of cause of death. At what time, how long does the certifier, the death certifier, has after the date to complete the medical certificate? This is what it means. So it's state specific, but most states give 48 to 72 hours post occurrence of death. So that this is the time interval you have to before completion of the medical certificate of cause of death. However, in certain circumstances, it may not be easy to reach on conclusions. So you could keep give the information, or you could just fill the medical certificate of cause of death and keep the cause of death or the manner. Those things you cannot conclude as pending for investigation. It has that section, so you could still fill and give the things that you could not conclude as pending. It has that section. But however, in 48 to 72 hours, you have to complete filling of the medical certificate of cause of death. So when you do the completion of the medical certificate of cause of death, as I have said earlier, it's usually an opinion. You're giving an opinion based on the information, the perspective, the understanding you have at the moment. So if you later on receive further information and you change your perspective on the cause of death or on the manner, if more information becomes available, if you receive more medical records, or however, if you may get to change your idea, your opinion, you can still make amendments. You can ask for, you can queries, you can present queries, and you don't discard the original certificate, but you can add another one where the amendments have been made, and those two should be kept together. So why are we concerned that the death certificate should be done in a standard manner and data should be recorded accurately in a limited time interval? And why are we worried? What's the purpose of this standard format for the medical certification of cause of death? In general, the death certificate serves as legal proof that the death has occurred. This is a proof that the death has occurred. But as I said, it's not a legal proof of the cause of death. The cause of death is an opinion. The manner of death is an opinion. So regarding those things, you're just giving an opinion. But the fact that you says that, so in regarding to the, but for the rest of it, it's to the best of your knowledge. So it's not a legal proof for the cause of death. So other major purposes for the death of the death certificate, it provides information for mortality statistics. So you can assess the health situation of the nation. So you can know what's killing the nation majorly. Is it accident, or is it are people taking their lives on their own, or is it homicides? Which one is increasing from the past year, or which diseases are increasing? Is it communicable diseases? Is it non-communicable disease? So it gives you a very good data regarding the mortality statistics. It gives you a very good view on what is killing the nation in major amount, in major gravity and weight. The other one is, since it's done in a standard format, it's a systematic catalog of cause of morbidity and mortality. We'll see how we contribute to the record of morbidity. However, since it's a death certificate, it's a direct catalog of mortality, and it also helps to pick priorities for funding and programs that involve public health and safety issues. So if the policies and the funders are reviewing these death certificates, they would know which areas to focus on, which areas need priorities, which areas need more support. So it has these purposes, and it's a very good data to base a nation's health policy on. It has also other purposes. For example, COVID deaths, as it has been a pandemic, and it has been a newly occurring pandemic. So you didn't know what were causing death. You knew COVID was killing people, but when you do autopsies and when you do death certificates properly, you can catalog so that next time you would know for newly arising conditions. You could also tell the pattern. So we'll see for the contents of the medical certificate of cause of death. These are the general contents that would be discussing in this presentation. Otherwise, it has different other sections as well, which are not convenient to present all in this case. So I've picked the major ones. I've picked the ones that we need introduction to, so that if we are familiar with these concepts, we can fill the rest of the certificates through practice and repeated exercise. So these are the components that I thought would be new and needed discussion, at least on this introductory session. So in general, don't bother if you cannot grab all the information I provide here, since the issue is new and it's globally known that physicians, clinicians struggle a lot with the death certificate as they're not familiar. It has a lot of sections. It's not done uniformly and it's not covered in the usual medical teachings. So don't frustrate if you cannot grab all the concepts here. Just use this as an introductory course, that there is a standard to understand that there's a standard death certificate format, and you as clinicians, as health workers, have the professional, administrative, and judicial duty to fill the death certificates. And it has these components, and use this as an introductory session. And I hope this inspires you to do more research, and hopefully we'll do in-person trainings regarding this topic. Otherwise, it would be very difficult for you to grab all concepts in one go. So don't frustrate, just use this as an introductory session. So this is the ICD-11 format in general. It has the administrative data. It has a frame A where medical data is entered, and frame B, other medical data, and the rest also. There is manner of death. There is a place to include if injury has happened and where. If it also has places for occupational diseases, for fatal deaths, and for pregnancy-related deaths. So this is the format in general. The ICD-11 currently, this is the recommendation by the WHO to use as a standard format. In contrast, this is administrative data, and everything else can be modified except the part where the cause of death is expressed in sequence. Most parts can be further adopted and further specified by the country, according to the country. So this is the data, administrative data. In the previous slide, where the ICD-11 format, you see a very small section for administrative data, but it barely says the sex of the individual, date of birth, and date of death. So that's it by the ICD. When you see to the US standard, it asks for a lot of detailed demographic data regarding where is the state, when did the date happen, street number, residential ID number, everything, a lot of details are included. So this is to show you that most of the sections can be modified according to the nation's policy and adoption. The next one is cause of death. This is one of the major entries of the medical certificate of cause of death. This is to be filled in a sequential manner from the underlying cause of death that occurs at the bottom line of frame A, part 1, line D, to immediate. That's the first line, line A, part 1, frame A ማለት ነው. So we'll see how we'd fill it in the next slides, but we need to first discuss what's the cause of death. This is a concept where most physicians are not very clear about. So the cause of death, by definition, is a disease or injury or a combination of the two. It could be a disease or injury. Injury has its own further classifications, but for this definition purpose, would just put it as injury or a combination of two. It's not always just natural or violent or accidental, or violent or unnatural. So it could be a combination of two. A disease could contribute or could complicate an injury and cause death, or an injury could complicate or cause a disease and later on could cause death. So it's a disease or injury. Cause of death is a disease or injury or a combination of the two that initiated and resulted in the termination of the life of the individual. In other words, it's the event without which the person would have continued to live, or it's the event without which the death of an individual would not have materialized. So the but-if test is used to single out the cause of death. So what does it mean? If the condition has not occurred, the death would have not materialized. That's what the but-if test means. So in general, deaths caused by disease or the aging process for most of the process. There could be minor contributions of injuries, but if it's majorly caused by a disease or the aging process, these are termed as natural causes of death. Violent or accidental deaths are termed as unnatural deaths. On occasions, the cause of death remains unknown, even after thorough search has been done on to collect information about the occurrence of death and the health of the individual. Even after that, even after post-mortem examination and ancillary investigations are done, cause of deaths become conspicuous. So in that case, it becomes unknown or undetermined. This could also mean that one cause of death remains equally at the end equivocal causes ታገኙ ማለት ነው. So where the disease or the injury remain of equal probability, you could also give undetermined or unknown causes. It's the same for manner of death. So it means when you don't know what caused the death in total, or when you cannot rule out one cause in a more probability than the other. When you have equivocal results as to the causes, it also becomes undetermined. It means that you could not single out a single cause of death for the case. So deaths could be of natural cause, unnatural cause, or of unknown or undetermined causes. For all deaths, causes are further divided as it could be natural or unnatural. It could the sequence of events that initiated and led to death are further classified into immediate, intermediate, and underlying mostly. Or intermediate causes are sometimes called as intervening causes. So what's the immediate cause of death? The death could be, like I said, it could be natural, or it could be unnatural, or it could be undetermined. If it's undetermined, you cannot go further. But if it's natural or unnatural, you go like immediate, intermediate, and underlying. So what do we mean by immediate cause of death? The final disease or injury or complication of these two directly causing the death. It's the final cause of death. That was immediately before the death happened. So intermediate is a cause that originated from the underlying cause and led to the immediate. So between the underlying and the immediate, we call intermediate. And the underlying is the starting process of the morbid chain of events. It's the disease or injury that initiated the chain of events leading to death. So usually when we say cause of death, especially in the forensic practice, when you say cause of death, it means underlying cause of death. We're usually concerned about that. But when you fill the death certificates, you have to fill immediate, intermediate, and underlying. And mandatorily, you have to fill the first section, the immediate one. In cases where the underlying and the immediate are the same, you fill on the first line, the immediate part. So we'll see further examples. This is the international form of medical certificate of cause of death. This is frame A, part 1. This is cause of death. So the last one is the first one you fill is the last event, immediate cause, and then intermediate causes, and then the last line on the D part. You could extend this if you have more causes which you think are important to mention. You could extend for a few more lines, but at the last one you have to mention the initiating event. And at the first one, you have to mention the last event before the date. So I hope it's clear. So let's see an example here, where there during the pregnancy, she had anemia all along, and after delivery, she had the anemia during the pregnancy duration of PPH due to uterine atony and died as a result of hypovolemic shock. So this is the case. What would be the immediate cause? It's the condition that was present and led to the final occurrence of death. So she died as a result of hypovolemic shock. We'll see later if it's recommended to mention hypovolemic shock. But for this example sake, so it says she died as a result of hypovolemic shock. So the immediate cause becomes hypovolemic shock. So a condition, the intermediate cause would be what brought the hypovolemic shock, but what originated from the underlying cause. So what brought the hypovolemic shock was the postpartum hemorrhage. Because she lost a lot of blood, she went into hypovolemic shock, and that was the final event that was present before she succumbed to death. So hypovolemic shock becomes the one we feel on the first line, on line A of part 1, frame A. So on the intermediate one, on B or C, we can feel as postpartum hemorrhage. And as an underlying one, it's the uterine atony that initiated the chain of events. Without the uterine atony, this whole thing would not have happened and shouldn't have died. That's what underlying cause means. Without the occurrence of this, but if the underlying condition had not occurred, shouldn't have died in the ማለት. So without the uterine atony, this chain of events would not have happened. So the uterine atony is the one you feel as underlying on the last line, and then postpartum hemorrhage is the intermediate, and the hypovolemic shock is the immediate, or the one you feel on line A. So here is another example where a patient who had been diabetic for 15 years went into HHS, hypersmolar non-ketotic coma, and she finally had acute renal failure. So this is acute renal failure is the final condition that she had that led to death. So acute renal failure becomes the immediate cause. In between, what led to the acute renal failure was the HHS hypersmolar non-ketotic coma. And she had the hyperosmolar non-ketotic coma because she was diabetic. So it is diabetes mellitus or non-insulin dependent one is written as underlying condition. So this has to be consequential. One has to cause the other. So this is an example of tabulating a cause of death. So here is another example. The underlying cause has to cause the intermediate cause, and this has to cause the disease or condition that led directly to death. So another example, squamous cell carcinoma of the left main bronchus led to cerebral metastasis, and that metastasis led to intracerebral hemorrhage. So there was no other condition before the date other than intracerebral hemorrhage. That was the last cause before the date, so it becomes filled on the first part. And squamous cell carcinoma of the left main bronchus, it becomes the underlying cause. So single underlying cause of death, this means where events happened spontaneously, or there was only one cause, where the underlying cause and the immediate cause are the same. So in that case, you have to fill only the first line, line A. Line A has to be mandatorily fulfilled in all cases, except in undetermined cause. So here it becomes, there is no consequence of one cause to the other. So in immediate and underlying causes become the same. So example is anencephaly, and interval was the birth. There's only one cause. Cause of death was ruptured middle cerebral artery aneurysm. So he had aneurysm naturally or whatever. So that ruptured. So that was the only cause. It becomes underlying and immediate. So it's filled on line A. Pneumococcal meningitis, and cause of death becomes the last one is osteogenic sarcoma of the left leg with metastasis. So you could, in this case, you could go on with the osteogenic sarcoma of the left leg as underlying and metastasis mentioned as intermediate, and if the metastasis complicated, that as an immediate one. But if it's due to the left leg with metastasis, in general, it just becomes one cause and it's filled on line A. So this is to show you that it's not always necessary that cases could have underlying, intermediate, and immediate ones. They could have single cause of death where the immediate and the underlying are the same, or where the underlying condition becomes the immediate one. It's the same condition that started the morbid chain and that caused the death. So examples of cause of death statements for medical examiner. This means for usually for unnatural causes. Medical examiner causes means the one you find due to violent or accident or suicides or sudden deaths. Those are the medical examiner cases usually. And in the case of sudden, traumatic, and violent act or accident, is antecedent to an injury entered, even if those two events are often simultaneous. So in these cases, traumatic death sinor or sudden death sinor, the recommendation is, even though in a very short time happened ቢያደርጉም, still injury or accident in the underlying cause መጻፍና whatever complicated as the immediate one መጻፍ ጥሩ ነው, usually for traumatic and violent or accident deaths, so that this gives the sequence of events, that the death was caused due to sequence of events, even though they occurred in short intervals. So here is an example. Stab wound of the chest led to hemopericardium, and this led to cardiac tamponade. So these things happened in minutes, but however, it's the injury, the stab wound, that caused this two further complications, even though they happened in a short interval. So in this case, especially in accidental and traumatic violent cases, it's good to tabulate the injury or accident as an underlying and the complication as an immediate. This is the condition where most clinicians are challenged: therapeutic complications and the death certificate. And we're usually worried if we mention therapeutic complications, if the clinician is going to be litigated for therapeutic misadventure or therapeutic wrong, usually. So we have that fear not to make the physician get litigated or so. However, when filling the death certificate, you should base on basic and simple facts, and you have no criminal to unnecessarily let go or let free, or an innocent to unnecessarily imprison. So you have to be free of those influences, and you have to base on simple and basic facts. So what's the thing with therapeutic complications regarding the death certificate? Unless it's a directly related event, the therapeutic complication. Currently, therapeutic complication is not even a recommended terminology. However, unless the condition was directly related and without the mention of it, the cause of death becomes completely omitted. You don't need to mention therapeutic complications on the death certificate. So medical interventions, diagnostic procedures, medical or surgical treatments should not be listed on the death certificate unless omission of them omits the direct cause of death. So like in this case, and there are also acceptable complications that were done that came as a result of life-saving activities from which the death finally occurred. So the clinician had to make that decision, even though the treatment had an undesired side effects to prolong the life of the patient, he had to keep giving. So this is, in that case, it's allowed to mention it. For example, here is a case where there is a doxorubicin cardiotoxicity, and that was an underlying cause, and it happened later. The doxorubicin cardiotoxicity led to congestive heart failure. So the doxorubicin had to be given, weighing the advantage. So unless in these cases where it's acceptable or where the cause of death becomes completely omitted by the omission of the medical mention of the medical intervention or the surgical procedure, it's usually not advised to mention therapeutic complications. So cause of death. While doing the cause of death, what are the general rules we have to remember? These are particular to the cause of death sections. A rational determination of what led to the individual's death should be made on the basis of the data at hand. So the more data you have, the highly likely that you can make an accurate diagnosis. So this is why you should consider the circumstances surrounding the death, and you should discuss among your teams. You should ask for laboratory investigations, radiologic studies, history, and autopsy findings. So before this, you should collect as much data as possible regarding that. That's what it means. So you can reach at a rational determination of cause of death. So it's important that you give the cause of death as accurately as possible, because like we said in the previous slides, the death certificate can be used to assess the mortality statistics of the nation. So if you're giving wrong cause of death, you shift the policy to give other wrong priority. You give a wrong picture of what's causing the death of the death in the nation. So that's why you should give as accurate causes as possible. When listing an infection, or even when you have to mention neoplasms or cancers, it's mandatory to determine the site and the causal organism. Also with metastatic or primary cancers, you should mention as primary or metastatic, and you should also give the histologic type. Don't give general like lymphoma, for example. So give histologic type and the anatomic site. Like you go like Burkitt's lymphoma, for example, if you have the histologic cytologic diagnosis, and you give at the NAIC or axillary or initial stage, or if it's metastatic one, metastasized to the other sites. Also, this is the mandatory condition we've been discussing before. There must always be an entry on the line for the immediate cause of death. Part 1, line A, this should be fulfilled. Even if it's undetermined, it should be given as undetermined. The rest of the lines could be omitted if the underlying cause is also the immediate cause, or if there is only immediate cause known, the rest of the conditions, the rest of the lines could be omitted, could be left empty. But the immediate cause, part 1, line A, should always be filled. So general rules continued. The length of time between the underlying cause of death and the immediate cause of death may be short or long, so it doesn't matter. It could be the underlying cause, maybe may have happened years ago. For example, somebody could have had diabetes. It started maybe 20 years ago. So complication that led to death happened today. So still, even though someone dies of diabetic ketoacidosis today, or any other complication today, diabetes as he was diagnosed was maybe known as 15 years ago. So underlying cause is mentioned as diabetes mellitus. You go like insulin dependent, non-insulin dependent, or type 1 or type 2. And then underlying would be 15 years. And then immediate could be as long as the diabetic ketoacidosis stayed before it actually caused the death. So the cause of death, the underlying and the immediate could be years apart, or it could be like we saw in the stab injury, it could be a few minutes apart, so it doesn't matter. But there shouldn't be any interfering cause that changed the course, so that the underlying and the immediate become disrupted. And this is what it means. There must be a continuous etiologic or pathologic relationship. It doesn't matter if the duration is short or long, but it must be a continuous. The relationship should be continuous. Medical interventions such as operations or treatments, like we discussed earlier, should not be mentioned in this section unless they were directly related to the train of morbid events. Currently, the recommended one is single cause of death approach. Immediate cause is a single one. It's not always easy to bring out a single cause of death, and it has its own, when you're putting something over another, you're giving that cause you're listing out a priority, and you're putting the other one in the shadow. So if we're using that data for later policy and priorities of the health of the nation, it could be made to undermine even equally important conditions because of this single cause of death approach. But however, this is the recommendation. This is the consensus by the WHO via the ICCD formats. So even though it has its own drawbacks, still the single cause of death is the current recommendation. So avoid reporting mode or mechanisms. This is the other area where almost all clinicians make mistakes, because we don't know what mode or mechanism, and we struggle to differentiate mode and mechanism from cause of death. So mode and mechanism or mechanism of death should be avoided generally. There are a few exceptions where you have to mention the mode or mechanism or other non-specific anatomic and terminal events. So the general rule is avoid non-specific terminal and anatomic events, and particularly avoid mentioning the mode and or mechanisms of death. So what's the mode and the mechanism of death anyway? Mode of death refers to the abnormal physiological state that existed at the time of death. So for the disease to occur, either of the three vital systems have to fail. And mode means which system failed first. So if you have a patient dying of pulmonary tuberculosis, we say the respiratory system fails. If you have a patient dying of intracerebral hemorrhage, we say the central nervous system fails first. But this is highly non-specific, and for death to occur, eventually the three systems will have to fail. If somebody has a failed lungs, irreversible failure, and then the heart and the central nervous system will eventually fail. So it's not relevant to mention which system failed first. It's not specific to the death, and it does not denote the underlying cause. For example, a person could die of a metastatic lung cancer, a metastatic cancer of, let's say, osteogenic sarcoma of the leg. So the underlying cause is the osteogenic sarcoma of the leg. But if you give mode as a cause of death, you are going to give respiratory failure. So it's not always related to the underlying cause of death. And the underlying cause of death is very important for the data. So don't mention mode, which means mentioning like respiratory failure, syncope or cardiac failure, cardiovascular system failure due to, or coma due to, or asphyxia due to እንደማለት ነው. So don't say these things, they're not relevant. Eventually, these systems have to fail. One of these things have to lead and the others have to follow. So this is like the patient died. This is like saying the patient died, and we know we're certifying date. So what's the mechanism? Terms could be used interchangeably. However, mechanism of death is the physiologic derangement or biochemical disturbance present at the time of death. For example, cardiopulmonary arrest, non-specific physiologic derangements as vital organ failures, or acidosis, or hemorrhage, inflammation, infarction. So these things as well do not necessarily indicate. These are just mechanisms, and avoid use of these methods, these words, and these etiologies in general. Also, as terminal events like asystole or ventricular fibrillation. So avoid these things, or also dehydration, coma, and arrhythmia. So avoid mentioning these things in general. There are exceptions where this mode or mechanisms should be mentioned, but it's beyond the scope of this. It's a whole lot of detail. We'll see the principles, but to discuss that in detail is a bit beyond the scope of this discussion. So the home take message for you is avoid mentioning mode or mechanism on the death while certifying the cause of death medically. So these are the principles in general where you could mention terminal events or non-specific anatomic processes or complications. So recognized potentially fatal complication of the underlying cause of death. For example, if you have to mention ketoacidosis in case of diabetes, it's a recognized potentially fatal complication, and diabetes has multiple complications. And decay by itself is a condition that calls for attention. So it's a recognized and potentially fatal complication. For this case, acidosis, like mechanisms like acidosis, diabetic ketoacidosis, could be mentioned. But it's important that you mention diabetic and ketoacidosis. You shouldn't just write as metabolic acidosis or electrolyte derangement. እንደዛ ተብሎ ሜንሽን መደረግ የለበትም። So this complication or this mode or mechanism constitutes part of the sequence of conditions. For example, if a person had a meningitis and developed fatal increased intracranial pressure, even though increased intracranial pressure is a non-specific mode of mechanism of death, it could still be mentioned. is part of the sequence of conditions that led to death. It's fatal and it's in the sequence. So it's not a symptom or sign. It's not like shortness of breath. Don't say that, or arrhythmia, or avoid those conditions. Its existence in the patient would not be apparent unless explicitly stated. If we omit the condition, even though it's a mechanism, it's like omitting the major cause. In those cases, you could mention mechanisms, and its inclusion does not represent an oversimplification of the facts. So these things, when you do the practice of certifying death, they become clearer. Otherwise, it would be just too technical to explain them here. In general, don't mention mode and mechanism on the medical certificate of cause of death. So how certain are we when we put a cause of death, when we put a certain cause of death as underlying, immediate, or intermediate? So as I have said earlier, the cause of death is your opinion. As a certifier, it's your opinion based on the circumstance, your knowledge, investigation results, autopsy results, and all. So it's just an opinion. You're saying, to the best of my knowledge, I think that death happened due to this condition. That's all. And it's not always easy to put a single cause of death to every case. It's not straightforward. So this is how you put cause of death uncertainty. Cases where the examination, including laboratory studies, reveal cause of death with a degree of probability nearing certainty, where you're almost sure. The circumstances are not necessarily incompatible with life. It necessarily does not mean a person who has those conditions should die, but the investigations, including laboratory studies, do not give any other reasonable explanation for the death. This is one case where you give a condition as a cause of death. For example, advanced heart disease or poisoning deaths. A person could be poisoned and he could still survive, depending on the dose and whatever. It does not mean necessarily it's fatal, but if you have no all investigations histories and all, could not give you any other cause, and if it's not something that you could ignore, you could put it as the probability nearing certainty, and you could put it as the cause of death. There are also cases where cause of death approaches probability as interpreted from the amnestic facts, the postmortem and other findings being non-specific. So you just have the history, and you only have, you don't have negative conditions to disqualify your history. So in case of electrocution and epilepsy, you may have the history, but you may not have anything on the body. So, but you know, electrocution and epilepsy could be potentially fatal. So you could give based on the history, the cause of death is whatever, electrocution or epilepsy. So cases where neither amnestic data nor the findings or laboratory studies help in arriving at some sufficient evidence. So in this case, it becomes conjunctural. For example, anesthetic doses, you may not have anything. And finally, where you could not give a cause of death, where you did not find any positive findings, or where one cause could not be any more probable than the other, you give undetermined or unknown. Otherwise, nobody knows what exactly caused the death. So who should give the statement? Which statement was more accurate? Those given by clinicians or forensic pathologists for the same case. So study shows cause of death given by clinicians is a mislabel or wrong in 25 to 50% of cases. These are cases where the clinician gave a cause of death and later autopsy was done. And in 25 to 50% of the cases, autopsy revealed a different cause of death. So it's advisable that potentially most days, potentially all days, or all hospital days be autopsied, postmortem examination be performed, because autopsy data is very dependable, and they would be compared with the clinical data. So in 25 to 50% of cases, the clinicians had a different conclusions as the cause of death. Moreover, clinicians struggle with filling the certificate due to because of unfamiliarity with the determination of, they're not familiar with the sequential, underlying, intermediate, and immediate cause of death. So they usually feel wrong certification of cause of death. So forensic pathologists could also give wrong cause of death. It was in 11% of the cases, according to this study. So the other content in the medical certificate of cause of death, in the internationally acceptable one, is the time interval. We'll see in the next one. So here, this is the slide we saw earlier. So we should give an arbitrary time. We don't know where the condition started. When we say diabetes mellitus of 15 years, maybe the patient had the diabetes for 5 or 10 years earlier, but it was diagnosed 15 years ago. So we give an arbitrary time. And also for the diagnosis of acute renal failure, when did it start? Maybe it started 10 days ago, but we diagnosed at 5 days. So it's the condition that started 5 days ago that led to the immediate cause. Again, this is an opinion. Maybe the patient had developed other potentially fatal complications, but this is the one we could diagnose. This is what it means. So time interval is another major entrance, and it's given for every cause of death that we put. So it could be time of onset for the underlying cause, and the next one is time of onset for the intermediate cause, and time of onset for the immediate cause. So in cases where the immediate and underlying causes are just one entry, like the one we saw earlier, there's going to be one time. It's not going to be an interval, it's just going to be a time of onset. So for example, anencephaly, if it becomes incompatible with life immediately after birth. So time of onset, and it caused the death at birth. Otherwise, while it was in the uterus, the fetus was alive. Birth caused the death, so interval becomes birth. Decapitation of the head by heavy weapon. This is instantaneous. At times, it becomes in seconds, so we say instantaneous. Pneumococcal meningitis, there is one entry, and this happened 3 days or 5 days or whatever. This time of onset for this one. And metastatic osteogenic sarcoma of right tibia, 4 years. So because if we mention one cause as underlying and immediate, it does not necessarily have to be close to death. It does not have to be in days or in seconds or in minutes. If we're giving an underlying cause of long duration as also the immediate cause, we could mention long duration. So other significant or other secondary conditions that contributed to the death. This is the other entry of the medical certificate of cause of death. So these are entered on the frame A next to the cause of death box. Still there on frame A and part 2. These are conditions that have contributed to the death or predisposed the individual to the death. But it's not the condition that started the chain of morbid events that led to the death. And they necessarily do not mean all chronic conditions are not necessarily significant other conditions. They could also be underlying causes. It depends on the case. For example, if a patient is diabetic, has been diabetic for 20 years, and he developed an injury, he was hit or he had an accident, he had a wound, wound became infected, patient developed sepsis and died. So the accident is the underlying cause of death. Diabetes becomes other significant or contributory condition. The diabetes did not start the death. So they could also develop after the morbid event underlying cause, has developed, and necessarily they don't have to be of longer duration, and they do not start. These are the conditions that did not start. They only contributed or predisposed the individual to that state. So here is an example we saw earlier. A woman who had anemia during pregnancy. She died of hypovolemic shock due to postpartum hemorrhage due to uterine atony. So in this case, like we discussed earlier, immediate cause becomes hypovolemic shock. Antecedent or intermediate cause becomes postpartum hemorrhage. Underlying cause is uterine atony. In this case, anemia is the pre-existing condition. It could make the postpartum hemorrhage and the shock worse, but it did not start the uterine atony. So it might have existed before it. So anemia is other significant factor that contributed to the death. So here is the part where you feel other significant conditions, secondary or contributory conditions, the one shaded in green. So other significant or contributory conditions, for example, a patient dying of mesothelioma due to occupational asbestos exposure could have been smoking tobacco for many years, chronic tobacco use. But if we have diagnosed that mesothelioma is due to asbestos exposure and that's what caused the death, if we cannot prove that tobacco is the cause of death, it becomes other significant condition. Here is another one, aspiration pneumonia due to Alzheimer's disease. Then other conditions could be remote cerebral infarct, right frontal lobe, or contributing conditions. So in this case also, a person dying of MI because of coronary artery disease, risk factors could be mentioned as other significant conditions that contributed to the death, like hypertension, diabetes mellitus, or obesity. Like diabetes mellitus does not necessarily cause myocardial infarct, or it's just a risk factor. We don't know it started the atherosclerotic coronary artery disease. So it's just a risk factor and it's mentioned as other significant condition. So manner of death, this is the another major entry. It's on the frame B. Frame A is for the cause of death and other significant conditions. Frame B is for other medical data, and manner of death is the major entry. So what's manner of death anyway? This is a condition that's not clear to most physicians, clinicians. The manner of death refers to the design or fashion in which the cause of death came into being. If death results from disease, manner becomes natural. From injury, manner of death is violent or unnatural. And violent or unnatural deaths are further classified into accidental, suicidal, or homicidal. Like the cause of death, manner of death could also be undetermined or unknown. Manner of death is as well an opinion by the clinician, and it's not settled by the opinion of the clinician only. It's usually in most states, it's the courts that settle the manner of death, whether death was accident or homicide or whatever, or natural. So the physician, the certifier, gives alleged manner of death, and like the cause of death, it's an opinion, and it depends on circumstances and traditions and information surrounding the death. Like the cause, information should be as well vigorously collected to determine manner of death. It could also be amended on later dates if you gain a different perspective from your original opinion. So this is the way, like the certainty in determining cause of death, manner of death is also the same. It could be undetermined if the certainty is less than 50%. If you cannot measure out one condition over the other, or if you cannot know, if you don't have the information. So reasonable medical or investigative probability, preponderance greater than about 70% shows this is more likely a suicide, or greater than 50% of evidence suggests to be homicide or so. So clear and convincing, 90%. Beyond any reasonable doubt, these two, beyond any reasonable doubt and beyond any doubt, are usually used for suicidal and homicidal deaths. Manner of death classification has sometimes traditional aspect. For example, we find a person who died of a road traffic injury that we usually say manner as accident. And when physicians are asked why do you give a manner as accident? It's someone who was driving that killed the other person, the pedestrian or the other passenger or whatever. So it's a loss of a life from one person done by the other. So this fits for homicide, but we traditionally give such deaths as accident. So in this case, we also have to consider intent in determining manner. Was there intent to kill, or was there intent to cause harm? So if there was unintentional use of intent to cause harm or death, or if there was gross negligence while we knew, or the person knew that the condition could be fatal, it becomes homicidal. Even though it's not intended, it still becomes homicidal. So manner of death is another confusing concept. So if you go back and forth, if you read it repeatedly, it becomes clear. So there are general basic rules for determining manner of death. As any rule, there are still exceptions. As we have said, manner of death determination is highly traditional, and intent is also given. So natural deaths are majorly, nearly totally due to disease or the aging process. So if evidences show that nearly total support for disease process or aging, we give natural as manner. Accident is when injury or poisoning causes death, and there was no evidence, no or little evidence to cause harm or to cause death. This becomes an injury. This becomes an accident in manner. Suicide, it's the intention that matters, self-inflicted, and there is the intention to do self-harm or cause the death. So these are the cases where collecting information is highly beyond noticing the pattern of injuries, the type of poison, and all. Information is and circumstantial evidences are very mandatory. So homicide is a volitional act committed by another person, and there has to be the intention to cause fear, harm, or death. It necessarily does not have to be intended to cause death. If there is the intention to cause fear or harm, it's the same. And death eventually occurred, it's the same. It becomes homicide. When you classify homicide, it does not mean necessarily there is a criminal person or a criminal intention. So undetermined is, like we said, when the collected information, when the certainty, probability of the certainty of one cause, of one manner, is no more compelling than the other. So when there are competing manners, when we could think that it could be an accident and it could still be a suicide, if evidences are equivocal, we give undetermined. So in general, when death involves a combination of natural processes and external factors such as injury or poisoning, it's good to favor the non-natural manner. If there is an injury or poisoning, give unnatural manners as accident, suicide, or homicide, dependingly. So another confusion for physicians is determining manner of death in therapeutic complications. Usually therapeutic complications, like we discussed, is not advised to mention them there, but if it's necessary, manner of death becomes classified if the death is related to high-risk procedures, but potentially fatal disease, or known complication of a procedure or treatment. Manner of death is considered natural. If we have done even though the treatment is very risky, and it's known, and it's still done by the physician, weighing the benefits to continue the life of the patient, we give natural. For example, like if we give digoxin toxicity, the patient dies of digoxin toxicity because of a heart failure, and digoxin was continued to be given, even though we know digoxin causes toxicity and which are potentially fatal, still risk was outweighed and manner is determined as natural. In contrast, when unexpected errors beyond the known complications or calculated risks of a procedure lead to death, the manner of death may be accidental. It's beyond the calculated death and there is no intention to cause the death, it becomes accidental. So these things, therapeutic misadventure, was the physician at fault? Was it an avoidable complication or whatever? It's usually, the decision is usually left to the court. So this is where the manner of death is tabulated on the ICD-11 format. So you could see the details for yourself, and there's also legal interventions and war manner of death. Now this two has joined. Also could not be determined like you do for the cause of death. You could also give could not be determined or pending for investigations, or you could just say unknown after all investigations have been exhausted. So examples of settling manner of death: if a person who had died of consumed a lot of paracetamol, died of developed hepatic necrosis. So cause of death immediate becomes hepatic necrosis, underlying becomes acetaminophen toxicity. And history says this is a known person with a depression, contributing factor become depression. And manner of death is suicide, the person attempted. So this is determined from a lot of things. For example, what are the common drugs? What is the drug shown on the toxicology studies? So if it's a drug that is usually used for suicide, suicidal drugs have their own features. So if it's suggestive, we could give the manner of death as suicide. It's less likely that we see the patient killing his own, taking his own life. So we determine manner from the surrounding circumstances and available information. So these are the principles that usually settle for specific types of cases that usually cause confusions with the physicians. So you go through them. It's interesting kinds of cases. For example, to classify manner as suicide, the burden of proof, you shouldn't worry that you should have 100% proof. If you have the evidences, more likely than not, that exceed more likely than not, you could give suicide. And like I said, it's just an opinion. So just because you're labeling as suicide, it doesn't mean that you have to prove 100%. It's the probability. When natural death occurs in a hostile environment, use the but if principle. For example, if a person dies of myocardial infarction while swimming, which one caused the death? Did he drown, or did the myocardial infarction cause the death? If you think that the swimming caused a stressful phenomena and caused the myocardial infarction, based on your information, you could give us otherwise. Had he not been swimming, he would not have that MI. You could give as unnatural, accident or unnatural. If you think the MI would have occurred anyway and the contribution of the swimming, the hostile environment is less, you give natural. So consequences of chronic substance abuse, example for alcoholic cirrhosis, alcohol withdrawal seizures, endocarditis secondary to IV drug use, emphysema of smoking. These things are usually designated as of natural manner. So the question here is, when a person uses alcohol or drugs or whatever, the person knows that he's harming himself. It could be in a slow process, but there's still intent to self-harm, and substances are still poisons. And this could be due to, this should be a poisoning case, and this should be suicide. That's the argument as to the natural manner. But the winning argument is chronic use becomes a lifestyle, and the intent to self-harm is subdued by, if a person is addicted to a certain substance, its addiction is a disease or a disorder than an intention to cause self-harm. So this is directly due to when it becomes the same substances, when it's due to acute toxic effects, it becomes accident. If a person, say, dies of acute alcohol intoxication, alcohol is still a poison. The person was conscious when he took the alcohol, but he didn't actually intend to overdose. And the substance use had a different intention. Maybe it was for recreational purposes. So so it's unintended side effect, and it's usually, if it's an acute effect of a drug or a poison, it's usually accident. So natural disorders precipitated by acute intoxication. For example, cerebral hemorrhage due to acute cocaine intoxication, it becomes accident. So the arguments are, as I mentioned earlier, the person used the cocaine and the intoxication was unintended side effect. So it becomes accident. There was no intent to self-harm and cause the death. Deaths due to predictable or essentially unavoidable toxicity, like we mentioned, it becomes natural. For example, if we are giving chemotherapy and that caused a bone marrow suppression with fatal infection or bleeding, and that caused the death, manner of death becomes natural. The benefit of the chemotherapy was outweighed, even though it was known that it had unintended side effects, so it becomes natural. It's not an accident. It was known. The physician administered the condition knowingly, so it's unexpected side effect, so it becomes natural. So here is a very interesting concept. Deaths due to vector-borne diseases like malaria and Rocky Mountain spotted fever, they're of natural causes. But when death occurs because of toxic envenomization, such as spider bites and snake bites, and anaphylactic reactions to these things, they become accident. So in the first one, in number 7, the reaction of the person that caused the disease and that resulted in the death. But when it's in the toxic envenomization, usually the duration is considered. And anaphylaxis is an idiosyncratic reaction, and it's different from person to person. It doesn't mean a bee sting would cause the anaphylaxis in everyone. So this becomes accident. Drug or food-induced anaphylaxis or anaphylactoid reaction is still accident. So these are recommendations. They have their own dilemmas and they have their own arguments. So go through them. So pregnancy-related diseases is another component. And now maternal diseases have their own ICD formats. They're under development. And cause of death classification have direct, indirect, and causes and such classifications. But for general, as general death certifiers, when you have women of reproductive age group, that is 15 to 49 years, you should always check the pregnancy section. Was the woman pregnant or not? Other states like the USA, they provide details, further details, better details than the ICD-11. So what you have to remember is that you have to give, you have to check in if the death was due to pregnancy or if the woman was pregnant or not in general during the death. So we'll see in the next section. So this one's the one on the left is the ICD-11 format, the WHO format. So the last section is for women to check about pregnancy. So you could zoom and see duration, if autopsy was performed, and all is filled in the previous sections. So on the US standard format, there is a better detail. It goes like about the duration of the pregnancy. When was the death? Was it after? When was the lady pregnant? Was she pregnant during the time of death, in the previous year, within 42 days of death, or was she not pregnant, or was it not unknown? So the US standard gives more details. So the take-home message for you guys is, for women of reproductive age, check the pregnancy-related box. Fetal deaths, this means perinatal, fetal, neonatal, and at times infant phases. Separate certificates should be filled if you have a mother and a fetus died at the same time. Also, if you have the fetus brought to you independently, you still have to fill a fetal death certificate. For most states, they use the same MCCOD certificates, but the US has a standard death certificate for the fetal death. So if you have the mother and the fetus dead at birth, the maternal condition, the one you gave, the maternal condition, the underlying condition to cause the maternal death, is the same condition that you feel as underlying cause for the fetal death. So this is, and then regarding time intervals, the WHO certificate recommends the time intervals be filled, but the US standard certificate focuses on if the causes were fetal or maternal, rather than the time interval for fetal death certificates. So this is the US standard. It takes a lot of details into account. It takes about the father, about the mother. Was she educated? Was she married? Where was the neonate disposed? And then what caused the condition of the fetal death? So what caused the initiation? What time did it survive? For how long did it survive? Did it have predisposing conditions diagnosed for the fetus and for the mother and all? And the weight and time of survival, estimated time of fetal death, how long did it survive? If there was autopsy performed, and also the US standard, I wish it becomes adapted for all nations. The fetal deaths part is more detailed. So in general, this is the summary. The international standard for MCCOD has two main sections, frame A and frame B. Frame A and administrative or demographic data. Administrative or demographic data can be modified as the adoption of the state. Frame A contains part 1 and part 2. This is mainly about the cause of death and other significant conditions, along with time interval for the onset and between the sequence of events. Frame B is usually, it's the one relevant to coding and epidemiological analysis. This is where the information for these cases are filled. You have, if there was a surgical intervention done, manner is also included in frame B. Fetal deaths, maternal deaths, if it was a pregnancy-related death, if it was an injury, occupational exposure, if there was a procedure done, and all are included in frame B. So, in general, when certifying the cause of death, discuss among your team and determine the sequence of events first before starting to fill do not formulate the sequence as you're feeling. Formulate the sequence of events first, which one to give as immediate, which one to give as underlying, if you're also going to give undetermined or so, formulate that first and then start to fill. Fill the form to the best of your knowledge. Do not forge cause or manner of death. If you don't know, then just mention as unknown or could not be determined. So remember, the death certificate is a legal document and can be shown in the courts of law. So you're not only filling wrong medical information, but you're also forging and getting between the justice system. And the last one is when filling the, unless you're typing, use black ink and do not delete or correct on the form. Fill the form without alterations or erasures. Write legibly. Do not use abbreviations in general. There are no standard or local abbreviations. Avoid abbreviations in general. Avoid excess explanations and excess medical jargons. Use specific and accurate descriptions, and make sure that your descriptions are fit in the ICCD formats. According to that, use acceptable explanations. Code the death. This is a very important part. And use your name and certifier profile and sign legibly. And remember, death certification is a professional, judicial, and administrative duty. So these are, this is my session in general. Sorry if I took more than intended time. So thank you for listening to me.
Thank you very much, Doctor. We can address some of the questions written in the Q&A section, I believe, if you have the time.
Okay. If the audience is okay, I could try to answer some questions. So Mahalit says, is it wrong to say dead on arrival when working at the ER? So dead on arrival is a technical term and it has nothing to do with the medical certification of cause of death. So it doesn't matter if you have the date, the dead body, even many days after the death had occurred. You could even get decomposed bodies or skeletons or so, if you're, say, forensic pathologists. So for those cases also, you need to fill the cause of death to the best of your knowledge. Otherwise, death on arrival is a technical term. It's just a definition. It's not a cause of death. It's not a manner. It's not anything. So just because you don't know the condition of the death, it doesn't mean you're free from certifying the death. You have to gather, you have to do verbal autopsy, you have to gather as much information, and you have to give cause of death, manner of death, and all the others. If the person was pregnant, or if it's a fetal death, whatever, as much as information, collect, tabulate a sequence of events as much as you can, and you still have to certify the cause of death. If you don't know, despite the collection of information, if you don't know, you can just give as undetermined or unknown cause of death and unknown manner of death. And at times you could tell the cause of death, and maybe you don't know the manner, or maybe you know the manner, but you don't know the actual cause. So whichever conclusion you could make, it's still your duty. It doesn't matter if it's death on arrival. There is no such thing as death on arrival on the, to my knowledge. Can immediate cause be cardiorespiratory arrest? So as we've discussed, cardiorespiratory arrest is a mode or mechanism. Usually a mechanism. Arrest is a mechanism. Failure is a mode. So it's not specific to the underlying cause, like I said earlier. So a person could die due to coma, and later there would be failure of the cardiac and the respiratory system. Otherwise, the person wouldn't die. So don't mention such things as cardiorespiratory arrest, coma, asphyxia, acidosis, infarction, inflammation, even hemorrhage. or ventricular fibrillation. These are non-specific. They don't tell the immediate cause, or they don't tell the underlying cause. And the underlying cause is very critical. So if it does not explain the underlying cause, don't mention it. So cardiorespiratory arrest, please avoid this term. Okay, third question, still by the same person, Mahalit. When that person comes to the ER, what do you do on immediate, intermediate, and underlying conditions? Like I said, when a dead person comes to the ER, look at it as an alive person. Like you would have clerked the alive person, this time the person in discussion, the person in question is dead, fortunately or unfortunately. So you still need to gather information from his, you still need to do examination, and you still need to gather information, do verbal autopsy. Clerk people that pick the body, how did they find it? Was he covered in blood? Was he vomiting? Was he alive when they found it? Did he collapse immediately? Did he seize? All those things. Or was he injured? Did the car hit him and run? Or did someone stab him? Or is he a known patient with some chronic condition? So collect these informations, do physical examination. Physical examination would be for two things. One is to certify the death, that the death has occurred, and the other is to certify the cause of death and to certify the manner as much as possible. So I can't tell you what's the immediate, intermediate, and underlying conditions just because the person arrived to the ER. You can't determine. It depends on the condition. So you need to clerk the circumstances, the conditions, the chronic conditions, and all. So remember, just because the person came dead, you're not free from certifying. So Ibrahim Mohammed says, is it a must to write only an entity as an immediate cause of death? At times, two or more processes may be immediate cause of death. Examples could be cited. Like I said, this approach, the current recommendation is single process approach, single cause of approach for all cases, for all causes of death. For the immediate, a single one, chain of events for the intermediate, and for the underlying. Yeah, like you said, two or more processes could appear as immediate, and two or more processes could appear as underlying one. But unfortunately, you have to pick one. And this approach has its own drawbacks, and it's being discussed, but the current consensus, it's all about consensus. So currently the recommendation is to single out a single immediate, antecedent, and underlying cause. Okay, how about dead on arrival? I think I have said this. So it's not just on arrival. You could also find bodies that have been dead for days, for years, for whatever. You could even have skeletons. We do skeleton examination as forensic medicine experts, and if you could find fractures and all, and if you could tell that they're of a recent one or due to an injury, or you still try to reach out cause of death and manner of death. If you have a skull, for example, that has been injured by a bullet, and there are places, there are signs where the skull shows, the bone shows when it's an injury due to a bullet injury. There are places, there are sites where the skull is damaged when a person commits suicide. There are sites that are usually injured by an accidental or homicidal firing and all. So you could still, we attempt as much as possible to determine the cause and the manner of death. So it doesn't matter if the dead person is arriving dead to your emergency session. It could even be dead for days, for years. You could have skeletonized bodies, decomposed bodies. It's still your duty. And it doesn't necessarily mean you have to do it alone. You could ask for postmortem examination and you could ask for help, but you still need to certify the cause and the manner as much as possible. What is the new ICD-11 definition of dead on arrival? Is it true that we can use dead on arrival if the diagnosis and died there prior to admission? I think I have included this one. To my knowledge, undetermined መሆን ይችላል. There is no such thing as dead on arrival. That's not the point of the death certification. The death certificate. When did it arrive is not the question, or how was it when he arrived is not the question there. Can you determine the cause and the manner and the other aspects as well is the question. So if there is a term to be mentioned as dead on arrival, I'm not familiar. Most of physicians use multi-organ failure or severe sepsis as cause of death. Is that a right way of reporting cause of death? Like I said, multi-organ failure is a non-specific mechanism of death. So avoid to use this as a cause of death. It's not a cause of death. It's a mechanism. It's the last physiologic or metabolic disturbance or anatomic failure that was present at the time of death. So it doesn't show why the patient died. You could have multi-organ failures due to a lot of things. So why do you mention something that's very broad as a specific cause to a death of a person? So avoid these things. Even sepsis is not recommended. It's considered as a mechanism of death. So you could give the underlying cause as an immediate one. In case, unless there is a particular indication that you have to mention sepsis. I was wondering why names or other specific identifications are missing on the administrative data section, even if it can be modified. Yeah, the administrative section on the ICD format does not give that. It does not give any on the ICD part, but I have seen formats, states that use the same ICD formats and put the name on top of the format as the codes also. But if you see the US standard, there is a place for the name and others, so it can be modified. So in case of patient who die after trauma as a result of deterioration of a stable chronic illnesses like a DM or cardiac illness, what's the immediate cause of death? That's complicated, chronic illness or the trauma. Chronic illnesses, stable chronic illness like DM. So it depends. Just because a person has a diabetes mellitus, it does not necessarily mean the morbid chain of events started because of his diabetes. It could, or it may, or it may not. Like if a person develops hyperosmotic ketoacidosis, diabetes could be mentioned as an underlying cause, and whatever immediate complications he had could be mentioned as immediate cause, like acute renal failure. But if a person had any diabetes 20 years later, let's say 20 years ago, and now he develops, he had a road traffic accident, let's say, and then he had a fracture, and then he was immobilized, and then he had maybe deep venous thrombosis, and he died due to embolism. So in this case, the diabetes becomes only a contributor other significant conditions. Maybe it has contributed to the person being immobilized for long. Maybe it has contributed for the wound not to heal as it would have on a person who did not have diabetes also. So just because a person has a diabetes, I cannot determine which complications he developed. And there is no constant immediate cause of death for people like people who has diabetes. It depends on the individual cause. He could die due to complications of the diabetes itself. In that case, it becomes the underlying cause, or he could have died due to other conditions, in that case, the diabetes may become a contributory, other significant condition. So it's the same as the trauma. Was it the trauma that caused the death, that started the chain of events that led to the death, or the trauma just, what do you say, contributed only? So it depends on the case. So that's for you guys to determine. Did Ethiopia adopt this WHO ICCD form? No, not yet. Or how is the practice in our health facilities? So it's a sad reality. Our health facilities, we're using a different death certification and form. And I usually even get death notification form as used as death certification form. So we don't have a uniform adopted ICCD form, and that's my long-term plan. If we could make it a standard as a nation, maybe that would be a much better practice. Is the standard format in our country that's in use? There is one, the one that Ministry of Health distributes, and it's different for different. It has different hospitals use their different names, and there's a uniform one for death notification form. That's to my knowledge. Death notification form is uniform, and death certification form is also uniform, but it's different for the heading is different. But as to my knowledge, adopted standard ICCD form does not exist. So I see in your questions that you're still struggling and frustrated that you have not grabbed the concepts. So don't be frustrated. Use this as an introductory course and read further and go back and forth with this materials and download the ICD formats and try to practice the death certification in your hospitals or clinics or health centers. So in that case, and with further discussions and trainings, the training should be done in person. It's very difficult through slides and when you have cases and when you practice, when you do the practical certification of the cause of death for individual cases, when you practice that, it becomes more clear. So I think I have. Do we have
Yeah,
more
Doctor. Yeah, I believe we finished them all up.
right? Yeah.
So on behalf of Blue Health Ethiopia and all our participants, we thank you very much for continually presenting on several sessions, and today's topic was a concerning one and important as well. So thank you very much, and we hope we will also have other sessions in the future. So Doctor, if you have any other last remarks that you want to address, please do.
So I would like to thank Blue Health for giving me the chance, the podium to speak on the topics of my concern. And it's my wish and goal for forensic practice to be, forensic medicine to be included uniformly in the undergrad, and for more physicians to join the forensic pathology department. And I also wish we could do this. We could have an accredited training on this one, which we could do in person. Those are my wishes, and go back and for it on this slides and download the ICCD formats and try to practice in your daily death certification practices, so that it becomes more familiar. Otherwise, it's a gist of things to grab at once. Even I have gone through this topics, and through it also has different materials, and you'll find different death certification forms on the internet, so it could be confusing. So even I have been going through these topics back and forth, even as a forensic medicine resident and even as a senior. So that's my recommendation. Go back and forth, try to exercise. So thank you for having me. Thank you for your time.
Thank you so
Thank
much.
you.
And definitely we will have an in-person session somehow. And we just hope that you continue working with us. Thank you so much.
Yeah, likewise. I really look forward to having the in-person session. That would be really helpful and make a lot of things clearer.
Great. Awesome. We'll definitely contact you. Thank you.
Thank you. All right. I'll be waiting.